Managing diabetes is really tough, especially when there are so few endocrinologists, highly coveted profession right now. So few, though, across the globe. It's why so thankful to have you volunteering your time once a month to be here, Dr. Manessis, to out of New York City, I might add, to answer questions that come in on a monthly basis from patients who do have type 1 and or type 2 diabetes. And we have quite a few that have come in. I think we have about 13 questions that have come in. It'll be like a speed round in the next 30 minutes, but just based on the patients that have been coming in to see you in the past month and things you've read, is there anything that's top of mind that you want to convey before we get started into the questions? Any interesting news or any concerns based on what you're hearing from patients these days?
Thank you for having in, Kim, and thank you to our to the patients and the attendees of conference. So I just got interesting that you brought that question because I just got back from the ADA, which was a long 5-day meeting with important information sharing regarding management of diabetes, type 1, management of type 2, and a lot about weight loss. A lot of information, a lot of studies about peptide medicine, and how that can help us lose weight, help us control the diabetes. And the big news is how we can put diabetes into remission and eventually prevent it. Okay, that's the big news right now, and that's the big push that I see from the majority of the presentations at the ADA.
It's
ADA,
interesting.
guys, is the American Diabetes Association. It's the major diabetes meeting in this country.
Yeah, I heard there was a little excitement there.
Oh,
With,
yeah. And I was part of it. Not part of it. I was not really part of it. I just happened to pass by from that area. Yes, a very well-known aviator chief of the diabetes care was escorted out because there was sharing some pamphlets regarding the NIH and how they, the political situations is influencing the research. That's pretty much what's the deal. But it was not nice what happened.
yeah, I heard that they were escorted out, with police and, so
They could
that
have
makes it.
done that much, much nicer. So yeah, there is some issues arising that, people from the organized committee resigned, the chief medical officer resigned. So yeah, it could have been done in a nicer way. That's for sure.
Yeah, a little turmoil and tough to tell whether it was the ADA or really, I heard there was Edichar that was supposed to be there, and there
Yes.
might have been more government related in terms of the call to the police. It's really a tough situation, tough to tell, and so I hope everything does work out in the right manner for the sake of the patients. And so we really appreciate you being there. We do appreciate all of the research that's being done, the
The science.
progress that's being made through the ADA and all of the participants. So we'll continue to support, all of you guys that are just making a difference and creating the change our patients want to see. And focusing there with Linda, she has type 2 diabetes, and what you were saying about weight loss. She is asking about all of the different weight loss drugs and diabetes/diabetes drugs. She said everyone's talking about Ozempic and Mounjaro and all of these newer medications. Are they really changing outcomes for diabetic patients, or are they mostly helping with weight loss?
It's an excellent question because in the beginning, the idea was, okay, they're just helping with reduction of A1C. But what we have seen over the last 7, 8 years, both with Ozempic and we start seeing with Mounjaro in terms of published data research, we see that it not only benefits the A1C, not only can drop the A1C to less than 6.5, but also it has multiple effects in different organs. meaning we have cardiovascular outcome trials that show that Ozempic and now Manjaro has been proven that it reduces the chances of having heart disease or having complications from diabetes. So patients who have a history of heart disease would not have less chances of having complications in terms of their heart. So there is an effect of a drug. We don't know exactly how it works, but definitely we feel like there's an anti-inflammatory effect in the heart. The same thing applies into the kidneys. Ozempic has been approved by the FDA as a medication to decrease the progression of kidney disease in patients with or without diabetes. And we already know that it helps with fatty liver. Fatty liver does not mean that our liver is just has extra fat. It means that fat sometimes can become very inflammatory to the cells of the liver, and then it can really cause progression of a liver disease to a much more inflammatory process, and eventually to what we call cirrhosis of the liver. So, and of course, speaking since this is a hotline regarding global peripheral arterial disease, we know that Ozempic, we have the STRIDE trial that have shown that it helps improve in patients who have peripheral arterial disease. Again, it has not been officially approved by the FDA for the management of symptomatic peripheral arterial disease, but as you can see, in all effects, there is multiple effects that's why we call it cardiometabolic renal liver effects that has in additional to the actual glycemic control effects that they have.
And Maria has type 2 diabetes, and you mentioned the discussion about remission. I don't know whether you were talking type 1 or type 2, but she's asking about type 2 in particular. She says, if I lose enough weight and my A1C returns to normal, am I considered cured, in remission, or do I still have diabetes?
Excellent question. And a very intriguing question, because first, type 1s, we cannot go into remission right now. We don't have anything that can get us into remission because type 1 is an autoimmune process. So the only way to go into remission is really to be able to regenerate beta cells. But in terms of type 2s, the current state of the management of type 2 is this medications that we have right now have the power and the ability to make the cells in the pancreas work as good as they can get. Meaning, yes, we can go into remission, and depending on the stage of the disease that they have, because if you're diabetic for 20 years, you're not going to go into remission. But remission means when your A1C is less than 5.7. So what we can see now with these drugs, patients can get into an A1C of less than 5.7 without requiring insulin, without becoming hypoglycemic, without requiring more medications. So that's what we call remission right now with the medication. Now, if it is accompanied by severe weight loss, or more than 5–10% weight loss, there is a possibility to remain into remission and then try to wean yourself off medication. Again, diabetes has a genetic profile also. Okay, so we cannot change our genetic profile, but we definitely can change our lifestyles. We can definitely change our diet. We can definitely start exercising more. So if we learn to be more, eat healthier and be more active, there's a higher chance of doing that, okay, of going into remission without the medications.
So, I mean, that's promising. It's encouraging that people have control and they can make a difference. They can create the change that they want to
Absolutely.
see for themselves. And I love that you're empowering people to do what's right for them, and that the medications are there if they need a little help, right? And we have Sarah with type 2 diabetes. She says, I've worked really hard to get my A1C down below 6.5. But my doctor says diabetes is still affecting my body. If my numbers are good, am I still at risk for complications like heart disease, PAD, or kidney disease. Now, you were mentioning 5.7, below 5.7, and I've heard this a lot, especially from type 1 diabetics. And maybe type 1 versus type 2, it's different, but I've heard that people say, well, my A1C is below 7, I'm good. I don't have to do anything else.
Oh,
But I even have functional medicine practitioners that say they want that A1C at 5 or even just below.
I don't know if there's any data regarding that, but there is definitely
I
data
haven't
right
seen any.
now. Yes. So it will be nice. The lower it is, probably the better it is for us. But right now, there is data that supports that if the A1C is less than 7, we have decreased progression of major cardiovascular episodes in our lives. Too tightly controlled A1C has been shown in the past when the studies were done with insulin Vedon that the risks of hypoglycemia did outweigh the benefits of getting a tighter A1C. So it's the first time the last really 8 years that we see a lower A1C result without really having hypoglycemia and weight loss. So it will be interesting how the future runs in terms of how low the A1C can get. Based on the data and based on how this medications work, there's only going to be, a certain point of A1C that we can get into because there's different panel. Well, I'm going to say this. There's different progression of a disease. Not everybody's the same. Okay. So not everybody's at the same stage of disease. Okay. So we have to make sure that the sooner we treat it, the earlier we treat it, let me say that, the most likely you can get into remission with medication and most likely get off the medication if it's feasible. But right now, the target is an A1C. The ADA recommends A1C less than 7. The American Association of Clinical Endocrinologists recommend an A1C of less than 6.5 together with weight loss for type 2s.
But the lower, the better.
The lower, the better. But I don't
Yes.
have a lot of data to support that if everybody's A1C is less than 6, that, that's going to offer great benefits in terms of cardiovascular endpoints.
So you've talked about some of this already just in the past few minutes, but more specifically for Mike, he wants to talk about peripheral artery disease with diabetes. He says, I was diagnosed with peripheral artery disease before anyone really talked to me about my diabetes. How closely are diabetes and PAD connected? And can improving blood sugar actually slow progression of PAD if that's the contributing factor?
That's a great question. Absolutely, improving diabetes can delay progression or prevent progression. Again, the issue about diabetes can affect every single artery in our body, no matter where it is. And that implies also to the peripheral arterial circulation. And the problem with type 2 diabetes is actually the insulin resistance. It's the insulin resistance that affects how the blood flow gets compromised in the arteries. And by saying that, when you have high insulin resistance, not only your sugars are elevated and your blood flow is affected by that, but also you have a high risk of damaging with that resistance your blood vessels. And when you damage your blood vessels, then you have attraction of inflammatory cells that eventually lead to the plaque formation. And that's how diabetes can really affect your. So there are multiple metabolic factors that you have to take care in consideration. Definitely the sugars, definitely blood pressure, definitely the cholesterol, the triglycerides. Definitely, you should not be smoking or having diabetes and peripheral arterial disease. It's a big no-no in the literature. So all those factors have to be well controlled. Definitely, they can be modifiable, and definitely they can prevent progression if they're controlled.
So, Susan has type 2 diabetes and chronic kidney disease. And she asks, my nephrologist keeps talking about protecting my kidneys, while my
Mhm.
endocrinologist talks about controlling my blood sugar. Which should I be more focused on?
That's a that's a great question also
Is she
because
having you roll up your sleeves with that nephrologist? No,
no,
focus
no,
on
no, no.
me.
Actually, they have a great point because we again remember before I mentioned about cardiometabolic renal
Yeah.
complex here, and everything is related to the insulin resistance. The same thing applies about the kidneys. Okay, so yes, controlling your sugars are critical to controlling your kidney function. Okay. And the first evidence of kidney disease, actually, it's not the blood test. It's what the sugar does, the elevated sugars does, and to the blood vessels that help you filter, the blood vessels to produce the urine.
Mhm.
So it is critical component to protect, to control your sugars, and then make sure there's no early damage in the kidney. So I would say that both of them are right, but the culprit is what? The
Sugar.
glycemic control. If the glycemic control is not good, your blood pressure is going to go up. That's going to affect your kidneys, and if it affect your kidneys, yes, we can control. We can take medications to prevent what we call a progression of a kidney disease. But if your sugar's still high, it doesn't really matter.
Okay. Tom, he wants to talk about prediabetes. He says, I've heard some doctors say prediabetes is a warning sign, and others say it's practically diabetes already. How seriously should patients take a prediabetes diagnosis? Because so many primary care physicians just brush it off.
Yes, and actually, that's the focus of. There was a lot of discussion about prevention at the ADA, and for a reason, because management of prediabetes, it's critically important. Not as important when somebody's A1C is very high, but if you can take things into consideration and manage or prevent progression of prediabetes to diabetes, that's a big step in your control, because there's definitely data that says that when you go from prediabetes to diabetes, your complication rate increases significant. So prediabetes, there is damage already in the beta cells, meaning the cells that secrete insulin have been affected. How many years? We think it's about 4 to 5 years before that the process started. But if you have prediabetes, you have to prevent from becoming diabetic. That's why the management of prediabetes is critical important.
Wow. My dad in 2001 was diagnosed with prediabetes, and he just maintained prediabetes for 20 years before he was ultimately diagnosed with heart disease. And
That's
finally, a dietitian with her PhD from Stanford said, Whoa, no one ever put you with a dietitian before to fix this? Are you kidding me? And we got his glucose under control. And we also found out he had an MTHFR mutation. So, we changed the diet and he had a clear PET scan just recently. So we're really
excellent.
happy. It makes a
Uh,
difference. It really makes a difference.
You have to give him credit. 20 years, he did not convert from pre-diabetic to diabetes. That's clinical significant.
Yep. But it was still damaging, right?
Insulin resistance can be damaging even with prediabetes. Yes.
Mhm.
Again, there's markers that we can use to see if there is an inflammatory disease already in your bloodstream. Okay, with prediabetes, and it warrants cardiovascular workup, no matter what, if you have prediabetes, just to make sure, because prediabetes is like having pre-blood pressure, pre-high blood pressure. It's like having your cholesterol being high but not very high. So it's considered like part of metabolic syndrome, and that means there's something brewing in your bloodstream that
Yeah.
can be inflammatory and can cause damage to your blood vessels.
And James is asking about type 2 diabetes. How much should I focus on glucose spikes after meals? Some social media influencers say the spikes are more important than the A1C. Is that true?
You know what? The spikes contribute to the A1C. So if we don't have an A1C, well, we're not going to know that we're spiking. But if you are in the pre-diabetic range, and your A1C is on the higher range towards the diabetic range. So yeah, you have to think about impaired glucose tolerance, which means you probably have higher spikes. So you definitely have some impairment in your insulin secretion and the insulin action. And you have to be careful with your diet or taking medication to prevent that spikes.
We have a few more questions here if you still have time.
Absolutely.
Okay. We have Carol with type 1 diabetes, and she is asking, this one might be a fun one. What are the biggest mistakes you see people making when they try to manage diabetes based on the information they find online?
The biggest mistake that we see is we generalize things. You have to individualize care. Okay. And that's one thing. Individualized care, if Karen comes, Carol comes, or Tom comes, not everybody's the same. Okay. Thank God. Okay. Otherwise, we will be living in the boring world. So we have to figure out type 1 is type 1, but not everybody's impairment in glycemic control is the same. So you have to figure out what's causing that impairment. And that's a combination of diet, activity, and management. So everybody is responsible for getting that under better control. In the media, there's a lot of, I'm going to say this, information that's not evidence-based. It's not science-based. And we just have to be very careful with the effect of the media on the management of diabetes, especially something like type 1s, which is a chronic disease that people have for years and definitely can cause complications also.
And Robert is asking about type 2 diabetes and chronic kidney disease. He has both. And he wants to know, are we seeing so much chronic kidney disease because of diabetes, because of high blood pressure, or is it really both working together? Um, because, from research that I saw, I think about um, hypertension together with diabetes really accounts for 2/3, right, of the
Absolutely.
CKD cases.
So you can get CKD you don't have to have diabetes to get CKD. You can have uncontrolled hypertension for whatever reasons, okay, primary or secondary, and you can get CKD. But definitely you have a higher chance of getting CKD if you have diabetes compared to the patients who don't have diabetes. Now, if your glycemic control is great, you don't have to worry about it. Okay. If your A1C is less than 6.5, we can say that for sure because we have the actual data until now. Should not be any progression in the CKD. Of course, there's other things that can affect chronic kidney disease in the presence of what? Even a well-controlled medications, other diseases, but medications, the big one, like using Motrin, ibuprofen, using antibiotics. So when you have CKD, there is a lot of other factors, confounding factors that can complicate the picture of the CKD in the presence of even a well-controlled diabetes milieu.
Okay. So I'm just looking over here at the next question. Angela, type 2 diabetes. Some people are using continuous glucose monitors even when they don't take insulin. Is CGM becoming the future of diabetes care for everyone?
Angela, yes, it is the future of care. Right now, the CGM is indicating patients who are on insulin, even if they're on insulin once a day, or they have hypoglycemia for whatever reasons. But CGM definitely has data that shows that it can prevent diabetes. If you have prediabetes, it can definitely help you control diabetes. If you're not controlled, It can help you wean off medications if you are doing well. So CGM eventually will be the standard of care in terms of monitoring your sugars, because it's not finger sticks just give you isolated numbers. With a sensor, you can get a real time information regarding what the effect of the meals that they have on your glycemic control. And in the next couple of years, eventually, it's expected that the CMS people will approve Medicare. The Medicare is going to approve sensors for everybody who are
Well,
diabetics, even without insulin.
I think we've talked about this before. I think everyone, even kids, should at least experiment with it at some point in their lives, even without diabetes, to learn to how food affects them. So
Yes, but they have to have diabetes. And, right now
now,
we don't have a lot
yeah.
of data about, patients who don't have diabetes, but we definitely have data about pre-diabetes to diabetes, or patients who are diabetic and then go on the sensor. They're doing much better than patients that don't go on the sensor.
So Kathy, with type 2 diabetes, said if you could give newly diagnosed patients one piece of advice that would have the biggest impact on where they are in 5 or 10 years now, what would it be? That's a give me question. She really teed that one up for you.
That's wow. That's the best, that's the most difficult question not to answer, because the answer is clearly related with lifestyle changes. Okay. Because that's the most critical aspect in the management of type 2 diabetes. If we are able to change how we think about food, change about how we feel about being more active, and see the effects of that those changes have in our body, I think long term that will be the most likely sign that you will be able to control or even go into remission in the management of type 2. So definitely lifestyle modifications are critical. Don't wait to treat if you have it, okay, one way or the other. And because there is data that the earlier you treat it, the better you do long term.
And here's another really fun one for you. David with type 1 diabetes. I've had type 1 diabetes for 20 years with all the new pumps and CGMs and automated insulin delivery systems. Are we getting closer to an artificial pancreas in our lifetime?
He probably has heard, David has heard this for the last 30 years.
Yeah.
We are closer in the presence right now. What we can tell David is that we do have, we are very close in the closed loop system. Closed loop system is automatic insulin delivery systems where you don't have to bolus. Okay, those are being tested. We have actually one of the algorithms in testing in our patients here. So pretty much the sensing that the sugars are going high while we're eating, and then they start giving extra bolus insulin, auto bolus insulin, to prevent post meal elevation. So right now we are definitely right there. Okay, in terms of that, having a pump where it will give us insulin. So tell that's one information for David to know. The second thing is probably before we are ready to do the transplant or the artificial pancreas, we might have what we call glucose sensing insulin. Like insulin, you give one injection a day, and the insulin gets active when your sugars go up. So we may have that in a couple of years from now, 2, 3 years. And the last thing, we want to believe this is early phase 1 trials, phase 2 trials. We may have what we call yes, artificial pancreas or pancreatic islet transplantation. So hopefully they will come before anything else. But again, it's not easy to do that process. But maybe the next 5 years we will have something to show to patients that it can help the management of type 1.
And it looks like we might have lost Kim there. She's on her way back in. What else do you have for us from the land of the future?
The line of future in term type 1s is better pumps, pumps that can sense when you're eating so they can bolus you. We can have better insulins, okay, faster insulins and insulins that sensing when your sugars go up. And eventually the most important thing is like what David said is to be able to get, we have data, preliminary data that shows that right now in how many patients, there were a few patients that we'd be able to transplant cells, pancreatic cells that were made in the lab, and they were able to live without insulin for at least a year.
I had a little bit of a glitch there with our internet. It's quite windy out here in California right now. So I apologize for the glitch, but thank you to Joshua, our producer, for pinch hitting there. And thank you for your patience, Dr. Manessis. I have two more questions for you. One is we ask all of our doctors, tell us about a case that you learned so much from that it's a lesson that other doctors and clinicians could learn from.
The most important thing about the management of diabetes is to listen to patients. That's what I found out is the most important aspect. And when you listen to your patients, you can understand certain behaviors. And that's really critical and important because if you want the patient to engage, you have to listen to them. You have to know what kind of job they do. You have to know what's the socioeconomic status, what they can afford for eating. You have to know if they can be active or not. You have to know how well they're sleeping. Both these are critical. So listening to the patients is the most important about the management of type 1 or even type 2 diabetes. It's not like going into the room, seeing patients, oh, check the A1C, oh, the A1C is high, increase the medication. Just talk to them. Talk to them. And
you would think it would be obvious, right? But that doesn't happen very often. I know when my dad was pre-diabetic, he got referred to an endocrinologist, and it was the very basic. Check your A1C. Here's the level. Do you want to be on medication? No. Okay. Eat right. Here's a dietitian referral, and make sure you continue to exercise. Period.
Yeah, we just have to help tell the patients how important it is. And when the patients feel they're being heard, they will do better.
And one more question. We have a series called Go with the Flow, and it's a motivational series for patients to walk, to grow their collateral vessels. And so I want you to give us your best motivational speech for walking as medicine for diabetics, heart disease patients, and chronic kidney disease patients, as well as PAD patients.
When we walk, we feel better. When we walk, there's better circulation in our bloodstream. When we walk, we can feel less foggy. We can feel, we can feel like there is better flow inside us and gives us more energy. We need more energy. And I think walking, you don't have to run a marathon. Walking can help you feel better. You don't need to run a marathon. You just need to be active. And we need to devote a certain time of our day, just for that. So we can feel that, guess what? I feel more, less depressed, less foggy. I feel better. Guess what? I'm going to cook tonight and I will eat healthier.
Thank you so much, Dr. Manessis. We really appreciate you joining us and coming on every month, volunteering your time to help answer so many questions and helping so many people out there. For those who ever want to join our live studio audience, you can always email us at info@padhelp.org, or you can just watch us right here on YouTube, youtube.com/the @ the way to my heart. Make sure you like this video, subscribe to our channel for more great content